Hello, good morning.
Good morning.
Morning.
Yeah, so who all are there on the dais? I heard Dr. Dwivedi. Is it Michelle Henry there?
I am there.
Uh,
We've got a
Yeah.
panel.
Okay.
My name's David Roy from St Vincent's in Sydney, Dr.
Uh-huh.
Umira, Dr.
Okay.
Pandey, Dr.
Okay.
Duavida, and Dr. Bayarana, and
Okay.
Dr. Grish.
All right, great. So welcome to Lucknow, and this is the case that we are doing. It's a TAVI case that I have planned. And with me is my team. Dr. Rupali is there, Dr. Manik is there, Ankit is there. So we are going to, we have done some things, and I'll show you the case. Can we see the case? So basically, this was a 75-year-old man with chronic lung disease and NYHA class 3 with the frail, is pretty frail, body weight is 48 kgs, and with all that, the STS score was about 4.1, with an echo-based peak gradient of 112 and a mean gradient of about 60. And so that's that. Can we move forward? There's some mild AR. Ejection fraction is okay. Next, please. Can we see the next slide? So that's the echo you see. So he has aortic valve calcification and it's severe aortic stenosis. You see some leak there, and there is a heavy mitral annular calcification. You can see on the posterior end of the mitral valve, there's MAC in there. Next, please. That's the gradient shown. Next, please. So that's the amount of MAC. You see, there's very heavy MAC actually. The coronaries are okay. Next. Next, please. So the calculated risk scores, STS, as I said, is 4.1. Euro is 4.9. Next. So that was the CT analysis. It gives us area-derived annulus of about 21.1. Actually, in systole, diastole, we measure. So diastole was about 21.7. Systole is about 21.1, something like that. And the coronaries have a good height. There is some, and the tricuspid valve. Can we see the next picture, please? So that shows the annulus level. So you see the calcium, and it's little oblong. So you have one diameter which is less, and the other is more. So the lesser diameter is nearly 17.8 or 18, and the longer one is more. So average is about 21.4 or 21. Next, there's some calcium slightly extending towards the LV outflow. You see the valve is tricuspid, and onwards, please. That's the implanter's view. So that's the speck of calcium on the right picture you see, which is extending slightly in the outflow. But the outflow diameter also we measured. It's about 21.8. It's about similar. So with that, we decided for, with that calcium and all, we decided for a balloon expandable valve in this patient. And we are going to implant the Merrill valve. Okay. So is the fluid bigger? The annulus, as you see, this is the sizing chart with a 350 millimeter annular area and a diameter about 21.1. If I use a 23 millimeter valve, it is about 18.7% higher. And if I use a smaller valve, then it will become under. So there's no way we can use a smaller valve. We usually try to keep it about 15%. So we'll show you how we'll do it. We'll probably underfill the balloon and then try to do it. That's what it is. So I'll just show you now the current pictures where we are. Next, can I see the live angios, please? The ones that we have just done. Can we have some fluid in? Okay. Not under. Okay. So that's the angio at the bottom. So that's the peripheral angio. So the division was low, so we could puncture reasonably okay. Fluid and yeah. Next, please. Next, please. So okay, so that was the basal angio. This was actually in the right sinus. Can we see the next one? Can we see the next one? Okay. So that's the leak, the mild AR, and you have the annular plane there. I think if you can okay. I think I'll give, because the wire has been lying there for some time. So, and the catheter, I just crossed it. So the pigtail is in. So I think I should not be wasting much time. I better move ahead. Can you increase some NORAD there?
You have increased the NORAD.
Because the systemic pressures you can show, it is slightly on the lower side, but I'll put the wire. This is the Confida wire actually, which I am putting in. There it goes. Okay.
Can I ask you two quick questions about,
Yeah, please.
about access? So how do you access the artery? Do you use ultrasound? And what do you use to close? Do you use ProGlide? or
Yeah,
ProStar?
ProGlide. I have already put the ProGlide in. Fluoro, please. I have already put the ProGlide in.
What about the access? Do you use ultrasound or just angio-guided?
Angio-guided. We have done the angio as I showed you.
The annulus calcium, or let's say the oblong aortic valve,
इसको थोड़ा सा
annulus,
pressure has to
does
go
it
up.
have any bearing in you in choosing your?
Just a
valve?
sec. I think some pressure has to go up. That's the thing.
Yeah, he's a bradycardia. You
I think atropine, please. Little
Atropine will help
atropine
here.
and yeah. Can we have the?
switch on the pacemaker.
Can we pace at about 80? Start pacing at around 80. 80 pacing. 70 पे पेस करो. हाँ लाइए. Let us have the balloon and come on, आइए. Come on. I think because the wire was in for some time, so that was the reason. Maybe there is some AR that is happening, so it's getting a little unstable. So I think we need to move forward. Don't pull the wire, okay? There is a stretch on the wire. Leave the wire. Okay, fix. All right. Okay. So I'm trying to do a balloon dilatation first. Cross. Just hold on. Okay, pacing at about 140. तुम करोगे इसको. Pacing at about 140. Pacing on. Inflate, deflate, pacing off. इसको शीट को पकड़ो, नेगेटिव करो. फुल नेगेटिव. नॉरैड डालो उसमें. शीट पकड़िए. Sheath has to be caught, yeah. Okay, leave it.
You can hear some
I
members
think
of
you
the
need
audience
to- you need
suggesting an
to-
echo.
I think you need to give some
Yes,
NORAD.
the two concerns for sudden hypotension would
Yeah.
be pericardial
I
effusion
think
or
some NORAD is needed.
the mitral valve apparatus being disturbed by the wire.
Echo देखो एक.
So if the patient
Echo
is not responding to atropine, I think it would be wise
Good,
to
so why
just
not
give
see
a
for the
look,
fluid there?
with echo to see whether there is some effusion and tamponade.
Yeah.
Fluoro, echo please. There's no effusion. There's no effusion.
Let's move fast.
Okay, come on. Let's get the valve in, please. नहीं but NORAD कितने पे जा रहा
Small
है?
amount of vasopressor will help here.
NORAD कितने पे जा
You've
रहा है?
already dilated
Huh?
the balloon.
Sir, I think
Huh?
we should deploy, sir.
Wire fixed.
The second possibility is the wire is pinning open an aortic leaflet or even caught up in the mitral valve apparatus.
Wire fixed. Yeah. So that's going through the Python sheath. That's the valve going up.
NORAD, everything you push. Give a bolus of
What is the
adrenaline.
pressure like?
Flexion, please.
Flexion करो.
Give a bolus of adrenaline. Give 1 ml.
So give at
मैं बोलूँगा उसे बाहर पकड़ो.
Wire fix करो. Okay.
Mark has crossed. It has crossed. Can you align the pigtail, please? Make it go to the non-coronary. Fine. Sir. चलेगा सर. जहाँ भी एक शूट लेते हैं.
Shoot angio test, please. Angio test, please.
Give a bolus of adrenaline.
Angio test, please. Come on. Inject. Come on, inject. Yeah, that's fine. AR is the problem.
That's fine.
Severe AR.
Where is the valve position? Looks okay. Huh?
I think it's fine. Run karo.
Valve position looks okay.
Sir, deploy.
Okay. All right. Pacing on, please. Pacing on, please.
No need for pacing.
कितने रेट पे है? Pressure. Inflate. 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 All the way, all the way, all the way. Deflate. Deflate. Pacing off. Pacing off.
There's no rhythm here.
A little bit of CPR may bring back.
Yeah, that's fine. That's wait. Pressure.
No, no, there's pressure. Pressure दिखाइए.
Keep the wire,
Pressure.
keep the wire.
Yeah.
I think you go offline and do some.
Yeah, I think
cardiac
इसको offline
assistance.
कर
Yeah,
दीजिए. Get it offline, please.
Yeah.
Give some CPR.
You do a CPR. So yeah.
इसको वो करो.
So can a transmission be switched
Can you
off
go
please from
offline
there?
now?
Yes, sir, you can go now. We are able to see you.
Yeah, actually, because we waited for so long with the wire in, that was the reason that the pressures kept on going down, and the patient was got unstable. And we then implanted the valve, as you saw, and it was almost asystole at that time. We almost did it with asystole. But then we resuscitated, and after resuscitation, now you see the pressures, we have the pressures back. We had to give some shocks also, but finally the pressures are back, the valve is in position. I've just done an angio from the non-coronary sinus. There is some AI there, I can make that out, but it looks like mild to maybe maximum moderate. I will
Tell me.
Sometimes we could
I'll
take some
just try
time.
to do a better angio, because that was very much inside the valve, and the pressures are now okay.
Dr. Ramesh and others, actually, when the patients are so low, can you stabilize the patient little with NARAD and then decide, unless you have
Yeah,
aortic
that is what we did.
aortic
but then-
regurgitation was severe, I think you could have taken some time to stabilize patient then.
Yeah.
Yeah,
Yeah.
yeah, yeah,
You can
So
guide
let us
with the
do
echo
the
rather than
angio.
doing angio at this stage.
yeah.
Well, the echo doesn't show more than how much? How much air was there on echo? Mild air. Echo shows mild. I'll do an angio. That's not an issue. We'll do an angio.
Do you have a clot in pigtails?
No,
tissue?
no, no,
Nothing?
no, nothing like that. Come on. Can we? Okay.
AR probably is not
Okay,
that
that's the
significant.
implanter's
Diastolic blood
view.
Diastolic pressure is
Okay, that's the implanter's view. The pressures are okay, and you are ready for the angio. Okay, so come on. Inject. Oh, there is hardly any AR. Yeah, there's hardly any AR. The valve is right in place. Can you see that? The coronaries are also filling well. I don't think there's more than mild. I don't think that time, the catheter was right deep into the sinus, and maybe it was distorting it to some extent. But right now, the valve is fine, and there is no AI. The pressures are okay. And what I learned out of this was that with the wire in, we can't wait for 25 minutes that I had to wait, because I had crossed the valve about just before getting live. And then, in spite of whatever happened, I thought they will come to us. You went outside somewhere. And in
Dr.
that
Goel,
20 minutes,
Is
the
he on a
pressure-
paced rhythm at the moment?
No, no, no. Can you reduce the pacing rate? He's on a paced rhythm. Can we see at 80 how much is it? Can we reduce it to 80? This is, sorry, that's his own rhythm now. There's no pacing, that's his own rhythm. Just that there is some widening. The QRS looks wider than what we started with.
Maybe some support can be reduced because he must be having an
Yeah,
aura.
because we pushed in a lot of support, so I'm
Yeah.
sure things are okay. But I can assure you this was only because I was waiting for 25 minutes across the valve with the wire in.
Actually,
and
that's
the
a sign
catheter
of
in.
that's a sign of critical AS. Once
Yes,
you go
yes,
across the wire
yes.
and the pigtail
So
across.
I think we learned that we should not be sitting across like that in the interest of life cases.
Yeah.
So because patient is very important, and but anyhow, with all the team that we had, we could bail him out, and I think this was a very strong and a very good bailing, if one would realize that, almost having arrest and then you getting him back. So
Yeah,
so
congratulations for an excellent, again, demonstration
Yeah.
for bailing out the
Yeah.
procedure, sir.
Yeah,
Wow.
and I'll just close the ProGlide from here, and this was a Python sheet and 14 French through which we have put the valve. Okay?
Okay.
So, fine. Thank
Thank
you.
you.
Thank you.
Thank you.